Okay, hi everyone, my name is Brian, and today I'm gonna go through one of the projects that we did for the CS 6101 class. We looked at medical dialogue generation, more specifically using knowledge distillation from BERT to a sequence-to-sequence or transformer model. Now, as an abstract, what we're focusing on is a dialogue generation system to basically take pressure away from medical organizations, especially in this period of need due to COVID-19. So as an overview, what I'm planning to go through in this presentation is first of all talk about the impact of COVID. I'm then going to talk about the applications of our system in the medical system. Then I'm going to talk about the task, kind of trying to give you an idea on what the datasets look like, and then about the method that we used to create the system. So first of all, I'm sure we're all very familiar with this. This is kind of like a graph of over time of both the cases in the United States of COVID-19 from early March up until November, and also the amount of deaths that have happened in the country. And as you can see, start of March, they started getting a lot of cases very rapidly, and because of that, they started also having a lot of deaths. Now, the main reason why there are so many deaths is because the people coming through their medical systems kind of overwhelmed their infrastructure, okay? So they didn't have any method to kind of release the pressure, and because of that, a lot of people died unnecessarily. And as a matter of fact, especially in Italy, they had to use ethical guidelines, but for example, the New England Journal of Medicine, where they basically gave a framework on basically who to prioritize. And this followed the disaster medicine kind of protocols, where for example, since they didn't have enough resources in their medical systems, they have to, for example, give age limit restrictions for who gets admitted into intensive care, right? So this is a very, very important problem that we were trying to help with, essentially. So for our particular medical dialogue system, what we're looking to do is basically act as a first screening barrier for patients, where they basically maybe are not too sure whether they might have COVID-19 and either need some assurance that they don't have it, or the medical practitioners would need more information on their underlying conditions, right? So what we're looking to do is basically allow the patient to interact with this dialogue system, and we're trying to extract as much information as possible from the patient, while at the same time not wasting the doctor's time if it's not necessary. So to give you an example, you have a patient that's very concerned about its health, and they just enter into the system whether they should get tested. Now, this is clearly not enough information for us to make a good judgment. So the NLG would respond with something like, please can you give me your symptoms, or can you give me more information on what you have? And in this particular step, we have automatically saved some of the doctor's time, right? So now a response would be generated, the user would get that response, and then they would themselves create a response to then interact with the system again. And with the second response, for example, they could say, okay, yes, we think that you should get tested, right? So all of a sudden you save some time, and then you've directed them towards a kind of recommendation, where that in this case they should be tested. So to give you an example on the data sets that we essentially have a patient which asks a question. For example, my chest hurts, do I have COVID-19? And then after that, you have a doctor response that says something like, that's not enough information for me to determine this. Do you have any underlying medical condition? And this basically carries on. It's not just one interaction. So after this, you could have the patient that replies to the doctor, and then again the doctor replies to the patient. And so we're essentially using the dialogue history in our particular model, and then we're using the final doctor's response as kind of like as our label in our training. So essentially, given this data set, we're essentially trying to also verify whether our method that we're using with our particular generation method, which is called CMLM, which I'm going to go through later what it stands for, can capture the medical information from the corpus. Okay, because at the moment, sequence-to-sequence models on their own are unable to capture this kind of medical information. So method-wise, as I mentioned, we're trying to do a dialogue system. Now this is an area in research to do with natural language generation, and a lot of the methods out there focus on trying to predict what should be the next word that comes up in a sentence, right? And when you're doing this, especially with traditional methods like LSTMs and RNNs, is that you come across this problem called neural text degeneration. And all that means is that while you're just taking a little bit of your previous sentence to come up with a new token or a new word, your window, it's not big enough for your probability distribution over all of your vocabulary for that particular token to not get stuck into potentially a repetitive loop. So yeah, you might end up in a scenario where you just keep repeating the same stuff over and over again. All right. So our solution is essentially to basically use guidance by using BERT. And this is the particular model that we've employed. Essentially, we have this part here that is just your standard natural language generator. Now, this could be a sequence-to-sequence model or even a transformer. In our case, we tested both, but for now, let's just assume it's a sequence-to-sequence model, and we can treat this as a student. Okay. So being a sequence-to-sequence model, you would have an input sequence. In our case, it's a patient doctor dialogue, and then our partial output sequence, which is our current output that we're generating on the go. Okay. And what we're doing, and this is our main focus for this particular project, is using this model up here, which in our case is BERT, as a teacher to produce a probability distribution over the vocabulary for the last token that you're looking at while you're doing the sequence-to-sequence model. And how we're doing this is basically we're also passing the input sequence, but then, so the input sequence is the patient and doctor dialogue, and also we're passing the doctor's kind of response. And how conditional mass language modeling works is that for your particular output, so in this case your doctor's response, you're basically masking, so you're just replacing some words with a masked token which basically hides this particular word to the model, and you're asking the model to try and predict what this word should be, right? So for a patient-doctor dialogue, you have multiple kind of responses in this case because you're masking different tokens, and you're just trying to predict these tokens on the go. And this is how we're fine-tuning this model. Okay. Now, after we fine-tuned it, we basically just use it as a normal feature extractor where we would put the the input sequence, again your patient doctor dialogue, and then your generated sequence here, and you're always trying to predict the last token, and for the last token it would give you a probability distribution over your vocabulary. And what I mean by that is that for that particular token you're trying to basically predict which word should go there with the most likelihood, right? So your vocabulary could be something like 30,000 words. So in this case it would be a vector of 30,000 words, and for each word you would have a probability and just choose the one with the highest probability, okay? And then, since you're doing one both from your sequence to sequence model, which is your student, and also one for BERT, which is your teacher, you then basically have two vectors with your two vocabularies, and for each part of your vector you're basically just merging them together. And the outcome of this is that you're basically inserting bidirectional information into your autoregressive model, which is your sequence to sequence model in this case, right? And this is a very powerful method to basically help this sequence to sequence model not end up doing neural degeneration, which is what I described before.